Hi, my name is Mike Pishvaian. I'm an associate professor in GI medical oncology at Johns Hopkins University School of Medicine. So pancreatic cancer is on its way to being the second leading cause of cancer-related death in the United States. So the obvious question is there anything we can do to prevent or to detect pancreatic cancer at an earlier stage, either from the get-go or for patients who've had a primary pancreatic cancer resected and they're being surveilled for a recurrent pancreatic cancer? So let me start with the first group, the ability to identify de novo pancreatic cancers. Unfortunately, we don't have any screening tests really for patients, for the general population, for patients with pancreatic cancer, the way that we have screening mammograms or screening colonoscopies. Part of that is because even though pancreatic cancer is going to be the second leading cause of cancer-related death, it's fortunately not all that common a disease. And so when you talk about screening a large population, it starts to lose the benefit. In addition, the screening tools that we do have, including MRIs and endoscopic ultrasound, are expensive and invasive, and so again, could not be applied to the general population. There are blood-based and urine-based tests that are being tested, but unfortunately to date, we really don't have a definitive screening test for pancreatic cancer. Now, I will say that there's a group of patients who are at high risk for developing pancreatic cancer during the course of their lifetime, and those are patients with a germline inherited mutation in one of the predisposing genes, including BRCA1, BRCA2, PALB2, CDKN2A. There's several others. And the patients who are identified as being high risk of having developing pancreatic cancer because of a germline mutation, there is an ongoing body of evidence to suggest that screening these patients may actually be of benefit. In the case of BRCA1, BRCA2 mutations, for example, the current NCCN guidelines recommend that patients undergo an annual screening test starting at age 50, and this can be an MRI and or an endoscopic ultrasound. And these screening methods, there's also growing data to suggest also that they are being successful because they're identifying the cancers in the patients that do develop the cancers at a much earlier and thus much curable stage. And in a publication from the Hopkins group, the resection rate, the cure rate of patients who were screened for pancreatic cancer was upwards of 80 to 85%, which is much, much higher than what we normally see for patients who present with symptomatic pancreatic cancer. As for the patients who've had a primary cancer resected and then are undergoing surveillance for potentially recurrent cancer, in those patients, we certainly are concerned about the development of metastatic disease. And so there is an algorithm for patients to be screened, or really surveilled is the right word, with CT scans, typically on an every 3 to 6 month basis for the first 2 years, and then annually up to year 5. Beyond year 5 is controversial. Some people will go up to year 10, but we really don't know for sure if that's the right thing to do. Rarely, there are some patients who also will develop a primary pancreatic cancer, and the pancreas remnant that was left over can also be at risk for developing a new pancreatic cancer. But when that happens, that's again generally the patients who have an underlying predisposition, such as one of the genetic mutations or a long history of pancreatitis, and they should fall under the high-risk screening protocols.